Hello and welcome back to the Venous and Lymphatic Forum. We are broadcasting live from the DeBakey CV Live studios at Houston Methodist Hospital in Houston, Texas. I'm Ulises Baltazar. I am your host. And before we get to the main event, we need to do some housekeeping announcements. First of all, if during the presentation or after you have any questions or comments, please feel free to access our media places so you can ask or comment or make any comments of the presentation. We'll, at the end of it, we'll do our best to answer the questions that you may pose. You have on your screen the way to contact us. Feel free to do that. Next, I want to show a brief calendar of the upcoming presentations. In March 24, next month, we are going to have a presentation of NOAC versus warfarin, the current status of venous anticoagulation. And many changes have happened in the recent months and years, and an update is necessary. So we will have Dr. Jenny Petrova from Methodist Hospital helping us with this presentation. In April is going to be a different setting because today's presentation, and we'll get to that in a minute, is extensive but is very important. So we might not have time for questions and answers today, but in April we'll dedicate that segment to answer the questions that this topic today may generate. Because I think it's very important to clarify whatever doubts or questions you may have. Then in May 26, we are going to have Dr. Joanne Lohr from Cincinnati helping us with the topic catheter-based intervention for chronic venous obstruction. So all that being taken care of, today we are going to talk about lipedema. And for that, many of you might ask what is lipedema, why a vascular surgeon needs to be versed in lipedema. I'll tell you why, because sometimes we get patients referred to us again and again with pictures or presentations like this that might be diagnosed as lymphedema and send these patients to us. And we don't know what it is. It's not quite lymphedema. There is no venous insufficiency, and the patients are bouncing from practitioner to practitioner without a diagnosis, and most importantly, without any guidance how to improve their condition. So this is lipedema. And I don't want to take too much time, but lymphedema is not lipedema, as I just mentioned. It's very important to know this. Lipedema is an abnormal deposit of fat in the lower body that extends from the hips to the ankles, and we'll review this with our guest today. It starts at puberty. I said from hips to ankles, 99% females, and about 50% of the time, at least one first-degree relative will be affected with this disease. And the triad normally that we encounter in these patients is allodynia. These patients have pain in the lower extremities that they don't consent to be touched. Is the history, the typical history is the patient that goes to have a pedicure and they don't like to be massaged. Second, they get bruises for light touch and they don't even remember where they hit or when, and they just see the bruise. And also important in the triad is symmetric. So for today's presentation, this picture, even some models out in the internet, they might have this problem of lipedema, and this lady unfortunately has lipedema. So I got into lymphedema, as I mentioned before, through my good friend Gunther Close. He trained me to become a certified lymphedema therapist. I had the honor to meet Dr. Foeldi, who is one of the cornerstone figures in the lymphedema arena worldwide. And through them, I have the privilege of meeting Dr. Tobias Bertsch. Dr. Tobias Bertsch is senior consultant at the Foeldi clinic in Hinterzarten, Germany, who arguably is the mecca of lymphedema and lipedema treatment. And he specializes in lymphology and bariatric medicine, and also serves as Secretary General of the German Society of Lymphology. Due to the difference in time, right now is midnight in Germany, Dr. Bertsch could not be live with us, but he was kind enough to record a presentation for us that we'll show in a minute. I encourage you to watch it, to pay attention, because it has a lot of good information, key information, and more than anything, true information that sometimes is difficult to obtain in this field. So please expect a very deep talk, not politically correct, something that we are not used to in our country, sadly. He is going to touch the facts. He's going to tell the truth about lipedema and the misinformation that we have had, and most importantly, how can we help our patients. So without further ado, here is Dr. Tobias Bertsch. I'll see you right after the talk is completed.
Thanks a lot, Ulises, for the opportunity to speak at this prestigious and important event. It's an honor and pleasure to spread the paradigm shift we currently see in lipedema in Europe, but which is in the meantime also well accepted beyond Europe. And I'm sure all of you have already noticed that my English is far away from being perfect. So I have to apologize for any inconvenience because of my bad pronunciation. Now, lipedema is, and I would like to share this fact right at the beginning of my talk, lipedema is far more than just big and painful legs. I would like to invite you in taking a closer look at lipedema, a look to throw a skeptical glance at this disease, a look that dips deep into the mythology, the fairy tales surrounding this diagnosis, a look that critically evaluates some popular lipedema statements. But I would not only like to discuss these critical statements, I also would like to broaden your view, your perspective on this disease. Lipedema, ladies and gentlemen, is also far more than simply a medical problem. This is why, if we take only a medical approach in the treatment of lipedema, this treatment is usually not very successful in the long term. In order to fully understand lipedema in all its complexity and its variety, we need far more than just medicine. And this is also what my talk will be about. Personally, I see far more than 1,000 lipedema patients every year, most of them of my outpatients at the Foeldi clinic in Germany, the others as a senior consultant during the ward rounds at the Foeldi clinic. And my colleagues and I are wondering that most of these statements we hear or read about lipedema are completely different to that what we experience in our daily work with these patients. And this wandering leads to questioning the traditional view on lipedema. And the result of this questioning leads at the end to the paradigm shift we currently see in lipedema. I divided my presentation in 4 acts. In the first 3 acts, I would like to show you why we need a paradigm shift in lipedema. And in Act 4, I'm going to introduce you the international consensus. Now, Act 1. Now, this is the traditional, the old view on lipedema. These are the criteria which define the disease lipedema in the traditional view. And apart from the fact we do not have any objective parameters to define lipedema, there's another essential problem, and this problem is the criterion edema. This criterion leads to a huge misconception regarding this disease lipedema, because when there's edema, like we see it in lymphedema, you have to treat this edema, you have to treat it with decongestion and with manual lymph drainage. Now, edema are by definition fluid accumulation, and this is a lymphedema, not a lipedema lag. And you can see fluid here by pitting edema or by high resolution ultrasonography of the soft tissue. At the Foeldi clinic, we use a 18.6 transducer, which has a great resolution. You see here the black spots, which is the fluid. And I see, as I already mentioned, more than 1,000 lipedema patients every year, but I have to admit nearly no one of my pure lipedema patients present relevant edema. Now let me visualize this with this patient. This patient is suffering from 3 diseases. She's suffering from morbid obesity. She has a BMI from 44. She's suffering from lipedema of the thigh and of the proximal lower leg. And she's suffering from obesity-related lymphedema in the distal lower leg. And we can see that this sustained pitting in the area of the lymphedema, the lower cycle, and the non-pitting nature of the soft tissue in the area of the lipedema, where she is suffering from the pain, which is the upper cycle. And if we use the ultrasound, then we can see with the high resolution ultrasound, we see the fluid here, the black spots in the area where we see the lymphedema and the obesity-related lymphedema, but there is no fluid in the area where we see the lipedema, where the patient is suffering from pain. No fluid. At the same time, there are so many statements, many articles emphasize the edema and lipedema. One, for instance, from Professor Schmeller, my highly respected German colleague, who states the extent of fluid accumulation is the major reason for sensitivity of the tissue to pressure and touch. Or by Karen Herbst from the United States, fluid overloaded interstitial matrix might explain the pain experienced by lipedema patients. But ladies and gentlemen, when these statements are correct, when they are really right, how would you explain it that patients with lymphedema was really fluid in the tissue, or patients with cardiac edema or venous edema? Why does these patients usually have no pain? These patients, they don't have pain, but they have a lot of fluid in their legs. And which edema, which fluid, which role does the edema play in lipedema? Now, this question is essential, because this edema is the reason our patients require, and in Germany, at least in Germany, gets MLD. Indeed, there is no scientific evidence for fluids, neither clinical assessment nor imaging techniques like ultrasound, CT, MRI, ever brought evidence for fluid in the tissue of lipedema patients. Furthermore, we do not see any histological findings for fluid in lipedema patients. And all these findings correspond to my clinical experience. Nearly no one of my pure lipedema patients present relevant edema. Now, let me introduce you to Mrs. Winter. She's not a lipedema patient. She's not a patient at all. Mrs. Winter is selling meat and sausage at my butcher's in Freiburg, my home city. And I had a conversation with her at the market. And she told me, of course, in the evening after long standing, I have sometimes slightly swollen legs. But she said, this is not a noteworthy problem. And she asked me, would you say this is a disease? And I would like to pass this question of Mrs. Winter to you, ladies and gentlemen. Would you call every little bit fluid after long standing in the evening, or which appears in the hot summer months, as a disease which requires treatment, a disease which requires MLD? Now, let's have a look to other countries. This is a quote from the Netherlands guidelines. They quote, lipedema is an unfortunate term as it evokes the idea of swelling due to fluid accumulation. However, it refers to swelling in the sense of an increase in volume due due to increased fat tissue. I like this statement. It's very helpful, and we see it a similar statement in the UK guidelines. Here you can read the word lipedema means fat swelling. It's not fluid, it's fat swelling. And this is from this is Tobias Bertsch, a German medical doctor and researcher, and he investigated in a multi-center study lipedema patients with high-resolution ultrasonography, and he states it has not been possible to detect fluid retention, so that the description of the disease as lipedema is misleading and should be considered and should be reconsidered. And this is René Hägerling from the Charité in Berlin, and he made great imaging techniques. He called it with the wiper method, to visualize tissue structures in three-dimensional presentation. And he concluded there are no characteristic change of the lymphatics and lipedema compared to the control group. And I would like to show you this great investigations, what he did. Look, this is a control group. This is a normal, a healthy patient. And these are the lymphatics of these patients. They are completely healthy. And here you see the lymphatic system of a lymphedema patient. You see a chaotic organization. You see the decongestion, the dilated lymphatics, different calibers. And this is a patient with lymphedema, completely normal lymphatic system. But when the lipedema includes no relevant edema, which correspond with our clinical experience, and when the lymphatics are completely fine, why are we even doing MLD? Is there any scientific evidence that this non-existent fluid is responsible for the pain or for the complaints of our patients? Not at all. Is there any scientific evidence that MLD or decongestion reduces the complaints of our patients? Not at all. So to summarize, we do not have any evidence for edema in the sense of fluid. So why decongestion? Why are we doing MLD? Now, Act 2. Instead of focusing on edema, we should focus on the real problems of our patients, which are, amongst others, first and foremost, weight gain and psychological issues. Let me start with weight gain. Now, I'm sure you know this colleague, this doctor, and when a patient who thinks she's suffering from lipedema enters the doctor's room, the doctor usually will take the medical history, and the sentence I hear every day 10, 12 times is this sentence: my legs becoming increasingly fat and are painful. And the patient sitting in front of me has a weight of 80 kilogram, 100 or 120 kilogram. And I think, please note, I think only the legs becoming fat? Or I hear this sentence: I gain weight because of my lipedema, or I can't lose weight because of my lipedema. Now, it's obvious that there's a close relation between obesity and lipedema. And everybody of you who treat lipedema patients know about this relationship. And the numbers which are published confirm this strong relationship between obesity and lipedema. These are the numbers of the Foeldi clinic. 88% of our patients we saw in the outpatient department, only in the outpatient department, had a BMI more than 30. So they were obese. And we have similar numbers from the Netherlands and from UK. And now an exciting question is, how can this close link be explained? Can we explain this link like some medical doctors or the media like to explain it, and by patients even more so? This is from a very popular doctors show in the United States.
This issue, lipedema, yeah, your body is just genetically programmed to retain, to form excess fat.
Now, let me emphasize, there is no scientific evidence for this statement. Not at all. This is misinformation.
Gap that's not related to diet and exercise is a result of this body programming.
Again, we do not have any scientific evidence for these statements. This is misinformation again.
Went through there.
The patient believed this.
What do you want people to understand about your condition?
What I want people to understand most about lymphedema and lipedema, especially lipedema, is that's what causes the excess weight. My obesity isn't from a poor lifestyle. It's from a medical condition that I was born with.
Now, I have no doubt that this patient is suffering from lipedema, in case she is suffering from pain in the soft tissue of the legs. But the disease which is in the foreground and which we have to focus is obesity. And there is no scientific evidence that lipedema leads to obesity. We have to focus on both diseases in this patient. We have to focus on the obesity, which is a disease, and we have to focus on the lipedema, which is another disease. But these misleading messages are going around the world, messages which say that lipedema leads to immobility, leads to sitting in a wheelchair. It's not lipedema which leads to sitting in the wheelchair. It's maybe morbidly obesity or severe arthrosis of the knee, maybe because of the obesity, but definitely not lipedema. We have pictures like these which are going around the world, and maybe some of these women really suffer from lipedema, but the disease which is in the foreground is definitely not lipedema. This is morbid obesity. This is the credo of many patients and patient support groups. I'm not fat, I have lipedema. Lipedema is blamed for women's weight gain. And putting it bluntly, ladies and gentlemen, these are fake news. These are really fake news. This is nonsense. There is no scientific evidence for these statements. There is no pathological explanation which support this view that independently from any weight gain, fat tissue is growing at the legs and the arms, and nowadays also the belly. I see in the meantime although today I saw a woman who told me she's suffering from lipedema of the belly because she has a huge belly and she thought this is lipedema. There is no scientific evidence for this popular view. Now, do we have any evidence, any scientific evidence that lipedema leads to weight gain? Not at all, ladies and gentlemen. It's not lipedema who leads to weight gain, it's obesity, and the scientific support for this statement is very strong. Now, Act 3. Now, these corrective statements that lipedema doesn't lead to weight gain is essential. However, we cannot leave it at that. We have to ask ourselves why lipedema, why this disease is currently experiencing such a rapid growth in attention, why lipedema is experiencing such a hype, not only in Europe, but also in the United States. And there are 3 points I would like to mention, 3 points which are connected closely together. First one, the obesity stigma, obesity bashing. Second, the mental stress and disorders of our patients. And third, the current beauty ideal. Now, let's start with the obesity stigma. Now, there's an obesity epidemic we see worldwide, and at the same time, we see an increase in stigmatization of obese people by the way, particularly by medical doctors. And stigmatization already is starting as a child. Obese children usually have a poor quality of life. According to data which were published in JAMA, the quality of life of obese children is similar poor to children diagnosed as having cancer. And the main reason for this experienced stigmatization and the main reason for this is the experienced stigmatization and exclusion. And obese children became obese young, and obese young became obese adults. And of course, there are many reasons why the soul of many obese people is sore, but the experienced stigmatization and exclusion contributes to an essential amount to the misery of our lipedema patients. And believe me, it's much more easier in these days to say, I'm suffering from lipedema, than to say, I'm fat or I'm obese. Now, the second, mental stress and disorders. Now, it is well established that there's a close relation between obesity and mental disorders. According to this systematic review by Lupino, a Dutch researcher, obesity increases the risk for mental dysfunction, but mental dysfunction also increases the risk to become obese. And now there's a very popular claim that lipedema causes mental diseases. But let me emphasize, there is no scientific evidence for this popular statement. Our data show that the opposite is true, that mental stress and disorders contribute to an essential amount to this disease we call lipedema. According to our study, lipedema, pain, and lipedema and pain, what is the role of the psyche? 80% of our patients suffered from mental problems. But please note, and this is very essential, this mental vulnerability already existed before the lipedema complaints started. Already before the lipedema complaints started. So purely in terms of formal logic, something that precedes the development of lipedema cannot be its consequence. So how can we explain this strong relation? Now, when the soul is sore, when the soul is sore, when the soul is crying, body starts screaming. This is a sentence which seems to be made for the majority of our lipedema patients. And the huge majority of our patients with lipedema suffer from mental issue, and around 80%, as I mentioned, suffer from mental issues and like depression or eating disorder or post-traumatic disorders. And this can increase the pain sensitivity. This fact explains the statement of our lipedema patients when they rate the pain on visual analog scale from 1 to 10. 1 is very mild pain, 10 is like amputation of the leg. I ask my patient, and then they're sitting in front of me and they say, my pain is 7, 8, 9, or sometimes 10. This is the third point, the 2 days beauty ideal. Unfortunately, this beauty ideal is completely ignored, is an ignored issue when we speak about lipedema. And lipedema and beauty ideal, we should consider together, but we should consider it in a historical as well as in a social context. Let me start with the historical context. Now, I'm sure you know all these pictures from the 17th century by Rubens, for example, like this. And today I see women with this body shape in my OPD. They ask me for liposuction. At that time, there were beauty ideals. but we don't have to go so far back. At the ISL Congress in Buenos Aires 1.5 years ago, I saw in the morning, I saw pictures like these at the Congress, at the Lymphology World Congress in Buenos Aires. This is a woman, she was diagnosed with lipedema, and she received liposuction. And I love to visit art galleries and museums when I'm visiting congresses. And in the evening or in the late afternoon at the art gallery, I saw pictures like these. These women were considered as beauty ideals at that time. Or in the morning at the Congress, I saw pictures like these, lipedema, and she was prepared for liposuction. And in the afternoon, I saw pictures like these, women which were worth to be painted. They were a model, a beauty ideal at that time. Look at the 1960s, Marilyn Monroe, look at her thigh. At that time, she was a sex symbol. She was admired by the American president. And today, we think this is beautiful. And these legs from Naomi Campbell and Heidi Klum, they lead me to the social context of this disease. Now, there's evidence that the media plays a powerful role in the formation, but also in the perception of body image. And according to a study of the University of Sussex, girls at the age of 5 to 8 are more unhappy, more unsatisfied with their body shape when they play with the Barbie dolls, comparing to those girls 5 to 8 who don't play with Barbie dolls. And I think you will agree with me that models like these are really rare. Instead, you see always these thin-legged models like these you see in nearly every women's magazine, TV, social media shows. And a normality is suggested that has nothing to do, absolutely nothing to do with reality. But when you see in the media, in glossy magazines, TV, advertising, always you see these thin-legged females. This can provoke social pressure that your own body is not normal, that your own body, your own legs are not healthy, are not beautiful, that you suffer from lipedema. And so, to conclude this, do we have any scientific evidence that lipedema causes mental diseases? This is a very popular statement. Not at all. Our data show that the opposite is true. It's not lipedema which causes psychological issues, but the obesity bashing, the previously existing psychological issues of our patients, and the social pressure of the ground of our current beauty ideal contributes to an essential amount to this disease we call lipedema. Now, what are the consequences of these new facts? There's, from my point of view, no room for doubt. We need a paradigm shift. We need a paradigm shift, which is the final of this lecture, and this paradigm shift was implemented by the European Lipedema Forum, which worked out the international consensus on lipedema. And this paradigm shift, ladies and gentlemen, is first and foremost a perspective change away from that what lymphologists believed to see in the last decades, which is an edema which needs decongestion, away from the belief that there's a lymphatic insufficiency towards the real suffering of our patients, the real complaints of our patients. And only then, when we are able to change our perspective, only then when we are able to see the real suffering of our patients, only then we are able to provide an effective treatment which is also successful in the long term. Now, what is the real suffering of our patients? At the first glance, fat legs and pain. Remember the typical medical history I mentioned, my legs becoming increasingly fat and painful. At the first glance, indeed, the complaints, the suffering of our patients is much more complex. And let me give you an idea with this picture. This bowl represents the diagnosis of lipedema. Imagine the diagnosis of lipedema as a pot, a kind of melting pot of all these problem areas. Often these are individual tragedies in the life of our patients. And lipedema as a diagnosis seems to offer a reasonable explanation. Some patients told me an excuse for all these tragedies in life. And of course, our patients are suffering from pain in the soft tissue, and we should treat this pain. But the pain perception is strongly depending on the psychological situation, on the mental stress of our patients. The data that are very convincing. And most of our patients suffer from weight gain and obesity, and many suffer from a poor fitness when they're obese or severely obese. And they suffer from stigmatization, from fat bashing, also because of their big legs and of their overweight. And as mentioned, they suffer from a lack of lack of self-acceptance because of the current beauty ideal. And if we're interested in a therapy which is successful in the long term, we should focus on all these different problem areas. Beside all, one thing is clear: edema is not the cause. It's definitely not the cause of the suffering of our patients. Now, if not edema is the cause of the suffering, what else? Now, at the European Lipedema Forum, we discussed these issues widely, and the European Lipedema Forum is an expert round. I invited in 2018 and 2019 lipedema experts from 7 European countries, and with several professionals like medical doctors, surgeons, physiotherapists, nutrition experts, obesity experts, psychologists, and together we met together in Hamburg, and all experts work in the national boards or guidelines and guidelines commissions, and have published about lipedema. And with the focus on the benefit for the patient, the consensus on diagnostic and treatment of the lipedema has been worked out. And this is all this scientific-based information has been published in October 2020 in the national consensus in the British Journal of Wound Care, and it has been worked out by renowned experts from the European Lipedema Group, and high-ranking experts from 10 European countries, but also beyond Europe, support this consensus. In the meantime, and the central statement of this European Lipedema Forum was: lipedema is not an edema disease. It's not an edema disease. So, when not lipedema, or when not edema is the cause, how can we explain the cause of the pain? Now, when the lipedema patient is gaining weight, and every patient I met in the last 15 years who's suffering from lipedema, who's suffering from pain, experienced the weight gain, sometimes 5 kilograms, sometimes 50 kilograms. So when the patient is gaining weight, then we see the patient is gaining fat tissue in the legs, and then we see in this fat tissue in the legs, we see a special hormone constellation. We call it, these hormones are called adipokines, and we see an increase in these adipokines in the fat tissue of our lipedema patients in the leg. And these adipokines can cause low-grade inflammation and hypoxia, and this can cause a very mild pain symptomatic in the legs. And compression and exercise reduce the adipokines and reduce the inflammation and reduce the pain. We have data by that from the sport medicine, from phlebology. But this is only one side of the coin. As mentioned, a huge majority in our population, 80% of the lipedema patients suffer from mental issues like chronic stress or anxiety or depression, eating disorders, and this can increase the pain perception. We have great data to that, and you can find the data. I will show you this data at the end. And again, chronic stress also can increase the low-grade inflammation, so we have a vicious cycle of this process. And the European Lipedema Forum also worked out a consensus which described the therapeutic concept for the treatment of lipedema. And what makes this approach special is the fact that this concept is focused on the real suffering of our patients. And to provide a comprehensive treatment, we need physio and movement therapy, exercise. We need compression therapy. Compression is very essential. But not because, let me focus this or emphasize this, not because of edema, but because of the inflammatory impact of compression. We need psychosocial therapy, weight management, self-management, and for a small minority, liposuction will have a good benefit. Now it's beyond the scope of this lecture to describe this concept in detail, but let me highlight some essential points of this approach. And at the end of my lecture, I will give you the sources where you can find a detailed description of this approach. Now, physio movement therapy. There's a strong evidence that movement, that exercise has a great impact on fat tissue, particularly on the inflammation of fat tissue. Remember, we have histological findings which suggest that there's a low-grade inflammation as well as hypoxia in the tissue of the lipedema patients, and exercise reduces this inflammation. At the same time, we see an increase in blood and oxygen supply, and we assume that both leads to a reduction of the mild pain at the fat tissue, and this assumption is supported by our clinical experience. But at the same time, the patients undergo a significant increase in fitness, which is measured by us at the beginning and at the end of the therapy. Now, as mentioned, a huge majority suffer from psychological burdens, which increase the pain perception, and physical activity can have a positive impact on mental health. It reduces stress and improves mood. It lifts self-esteem and lowers risks of depression and anxiety. And all these are issues of our lipedema patients. And the data for these statements are very convincing, very convincing. Now, let's have a look to compression. At the ILF in Rotterdam, I had a very nice conversation with Professor Hugo Bartsch, the world-leading expert in the field of compression, and many call him the compression pope. And we had a very nice conversation about lipedema, and I asked for studies which describe the impact of compression on inflammation of the tissue. And 10 days later, after our conversation, he sent me this package. I took a picture with studies about this issue, and furthermore, he marked the relevant points in these studies with a yellow marker. I was deeply impressed by the commitment of Hugo Bartsch. Hugo Bartsch is over 80, and I was really impressed. And so there are some of these data which show the impact of compression. Unfortunately, we have a lack of data. We have a lack of data regarding the the impact of compression on lipedema. And it would be great if we could create studies with this issue. We only have our clinical experience. Look at this. This is a wedding, and this patient shows a strong commitment. She was also wearing the compression stockings during her wedding. Next point, the psychosocial issue. Now, it is crucial understanding the link between depression and physical pain. This link is particularly important for patients with lipedema. And I already mentioned our own data to this topic, and these data show that there's a strong relation between the severity level of the mental issues and the severity level of the perceived pain of our patients. And there's a strong evidence that psychological treatment is for patients with chronic pain is crucial. And you know that our patients with lipedema suffer from chronic pain. Now, weight management. Most doctors recommend dieting if an obese patient enters the doctor's office. Dieting is the most popular therapeutic approach which is offered when a patient is overweight or obese. And we should rethink this therapeutic approach. Let me give you a few numbers. Now, 91% of women surveyed on a college campus had attempted to control their weight through dieting. 22% dieted often or always. This, ladies and gentlemen, is sad. 6 years of the women spend 6 years of their lives on a diet. These are data from the UK. And this is sad too. 50% of the 9 to 10-year-old girls in the United States are dieting. 50%. Ladies and gentlemen, this is a tragedy. This is definitely a tragedy. And 95% of all dieters will regain their lost weight in 1 to 5 years. 95%. The data to that point are very clear. These are peer-reviewed studies of the last decades from prestigious journals which show the failure of diets in the long term. Diets, ladies and gentlemen, fail in the long term. For this reason, there's a consequence, as a consequence, we strongly advise our patients against dieting. We say no more diets. Diets make you fat and sick. Diet and exercise leads to a dead end. The study situation for this conclusion is overwhelming. Instead of diet and exercise, we at the Foeldi Clinic, we say stabilize and exercise. Stabilize and exercise is our credo at the Foeldi Clinic. In other words, it's better when the patient with lipedema and with obesity can stabilize the overweight or the obesity than to experience a yo-yo effect with an increase of weight and at the end with an increase of the volume of the legs and with the worsening of the lipedema. Instead of diet and exercise, we teach our patients what is unhealthy food and what is healthy food. No special diet, just healthy and well-balanced food. At the same time, we draw the attention on the fact that not fat is the culprit, but sugar. Our sugar consumption contributes to an essential amount to the obesity epidemic we see worldwide. Now, sugar and obesity is an own topic where I could lecture another hour, so I will leave it at that. And if your patient is severe obese, if the patient has a BMI 40, 50, 60, if your patient say, I don't want to live with this weight anymore. This is not my life anymore. Then think about bariatric surgery, think about obesity surgery, which is, and this is important, integrated in a long-term multimodal concept. There are some different bariatric procedures, but the gastric sleeve and the gastric bypass are best proved regarding the benefit, the benefit profile. And for this approach, for bariatric surgery, we have multiple data. We have long-term data. We have 5, 7, 15, and 20-year data. And all these data, long-term data, which are published in prestigious journals, prove the success of this approach. Now, this is a patient who is suffering from obesity and lipedema, obesity plus lipedema. And look, this was the patient after gastric sleeve. Look at the size or at the legs. The volume reduction is from 18 to 9. And you will hear in many lectures or magazines or social media, you will read that weight loss is not effective in this disease. However, our clinical experience and our studies, I will show you a little bit later, with this approach we used since 2008, show that the opposite is true, that nothing could be further from truth. Our data show that weight loss by bariatric surgery is the best treatment to cure this disease. So look at this patient. But let me emphasize, obesity is definitely not a problem, not a disease a surgeon can solve alone. Bariatric surgery, which is not integrated in a multimodal concept, will fail just as diets will fail. And this is the concept used at the Foeldi clinic. And you can see how many colleagues, how many disciplines work together in this bariatric team: physiotherapists, medical doctors, psychologists, bariatric surgeon, obesity and nutrition experts, and also plastic surgeon work together and pull together in the same direction. Now, this is a patient also suffering from lipedema and obesity. She received a gastric bypass. And she was, by the way, she was, another doctor recommended her liposuction, and we could convince her that liposuction would definitely not the right treatment for her. Personally, for me, liposuction for this morbidly obese patient is a crime. It's really a crime. We could convince her that bariatric surgery is the best option for her problem, and we admitted her in our obesity program and prepared her for a gastric bypass. And this was the patient 10 months later, and she was free of any complaints. So we call this lipedema in remission. Or this patient was a 61-year-old patient suffering from lipedema and obesity. Look at the legs. She was free of complaint, and there's immense improvement of her mobility. Now, together with the University of Freiburg, we elevate our clinical experience, and we have now since 2008 with this approach, and we conducted a study about the impact of bariatric surgery of the volume of the legs. And so as you can see here, the volume, here you can see the thigh of the volume, the thigh you see the volume reduction. The red curve is the lipedema, the green is the control group, and you can see after 2 years we have the similar, even a little bit better for the lipedema group. The thigh reduction was a little bit better for the lipedema group in our study. And maybe to visualize this again, look at the, maybe you have on the left picture, you look at have a look at the thigh. This was the patient 10 months later. She was free of complaint, so we call this lipedema in remission. Now, self-acceptance, next, self-management. Self-management is another point we have to consider. That means self-management means we have to build bridges to our patients, to build bridges how they can transfer their achievements they reached during the treatment into the daily life and work. And personally, for me, this is the tricky point. We have to work on this. At the Foeldi Clinic, we also work on concepts to transfer these achievements into the daily work. Liposuction is the last point of the concept we worked out at the European Lipedema Forum. And these are the criteria which we define that liposuction makes sense despite conservative treatment still complaints. Psychological assessment is essential to exclude severe eating disorders or other severe psychological problems which can hinder the success of the liposuction. Weight stability is very essential when the patient experiences always a yo-yo, and then after the liposuction, the patient is gaining weight. You won't have a success. Only the BMI should be at the maximum of 35. If the BMI is more, then we should treat the obesity first. And if the BMI is more than 35 or then 40, we should think about bariatric surgery. Now, this is a patient with a BMI of 30 who fulfilled these criteria, and she has a great benefit from liposuction. She was also free of complaints, but of course she needs further compression, but then she was really free of complaints. Although this patient, she was also free of complaints after liposuction. But please note, these are the wrong patients. Both patients were suggested by liposuction. Again, for me, this is a crime. Liposuction is definitely not a method to treat obesity. Now, this is the concept of the European expert group. The therapeutic approach is focused on the real complaints, on the real suffering of our patients, and not on any edema for which we do not have any scientific evidence. And at the Foeldi Clinic, which is the European Center of Lymphology, we already treat our patients with these new concepts since 1 year, and we started to evaluate our therapeutic approach. We use the SF36, and I'm glad to say that our first results are promising. And the consequence of this paradigm shift in lipedema, the result of this holistic approach, which is focused on the real complaints of our patients, are happy patients as well as happy therapists and happy doctors and the Foeldi Clinic, and I guess not only at the Foeldi Clinic. Now, all the scientific sources or references you will find in the international consensus document, which has been worked out by the European expert group, and as mentioned, high-ranked experts from 10 European countries, but also beyond Europe, support in the meantime this consensus. Ladies and gentlemen, paths are made by walking. Let's walk this part together, and this is my take-home message. Don't believe everything you hear or read about lipedema. Take a closer look and remain critical. Thanks a lot for your attention, and thanks a lot, Ulises, for the opportunity to spread this paradigm shift in your great event. Thanks a lot for having me, and goodbye.
So I had the privilege of meeting Dr. Bertsch in one of the meetings, and the first time, again, this is a very amazing talk, full of good information, controversy, and the scientific basis for us to reassess this kind of patients. And I want to emphasize once more before we say goodbye that why a vascular surgeon needs to know about lipedema. These patients often are referred to us for swollen legs, for lymphedema that clearly is not, or venous insufficiency. It doesn't mean the disease is not interlaced, but we need to be able to at least help these patients, guide them, give them some comfort, because they've been back and forth through many specialists and they are stressed, like Dr. Bertsch mentioned. Well, we have a few questions, and now we are not going to address them right now, as I said, because we're already 7 minutes after our normal time. I hope you found this talk interesting. I really do. In the meantime, I want to wish you well, and we'll see you next month to discuss anticoagulation in vein disease, and we hope also that might be interested for you. Thank you so much. God bless you, and we'll see you next month. Thank you.